had immediate release or Sinemet, carbidopa-levodopa, for 50 years. And it seems like a lot of the different advents for how can we improve upon Sinemet or the traditional levodopa therapies we have is can we give it in a way that helps it last longer or that keeps blood levels from pulsing up and wearing off. And so kind of what can we do from a continuous release standpoint? And so Duopa, kind of the intestinal gel of levodopa was kind of the first to come along. And I know that other folks have looked at an accordion pill, which wasn't successful, looking to see can we kind of trickle levodopa into the gut slowly. Can we look at subcutaneous delivery? So that's kind of, can we reduce off time by keeping people on longer? The opposite end of the spectrum now is kind of short-acting dopaminergic therapies. And we've had different stuff on the market before. There's been Parcopa, which is a sublingual form of carbidopa-levodopa that gets kind of swallowed and potentially kicks in and absorbed a little faster for people who wear off unexpectedly or want a faster time to on. The injectable apomorphine has been available for a number of years, and that's been on the market to kind of help people with off time, or again, trying for morning off time, trying to decrease the time to on. And now coming to market, we've got inhaled levodopa, again, for people who have an unexpected off, and other formulations that are in the pipeline and in development. So I think there's a place for both. I think the Holy Grail outside of disease-modifying therapies is, can we come up with a way to keep dopaminergic therapy steady and at a satisfactory level throughout the day? That's kind of the continual therapies. Until we do that, or with the therapies we have now, as long as people are struggling with turning on, wearing off, turning on, wearing off, and kind of this motor fluctuation cycle that we're all too familiar with in Parkinson's, I think there's definitely a place for development of drugs that can help alleviate off time in a rapid manner, or alleviate wearing off in a rapid manner that's come at an unexpected time. The ones that we've had on the market, so you look at apomorphine, which is a subcutaneous injection, and I think there's a proportion of patients who, despite having wearing off, are uncomfortable with the idea of an injectable therapy. The Parcopa therapy, which I referred to before, is still an oral therapy. It still gets absorbed through the gut, and so the same issues sometimes that we see with regular levodopa therapies still apply to Parcopa, that it doesn't kick in as effectively as we would like. And so there's some drawbacks in that they're not as, either one, the mode of administration is not as desirable, or the time to on is not as idealized as one would hope. And then getting to the inhaled levodopa therapy, where certainly a different route of administration. You don't worry about things like gastroparesis or slow gut transit time kind of affecting its absorption. You get an inhaled levodopa that's going to get absorbed through that respiratory mucosa into the bloodstream. And I think I think some patients are comfortable with that. Some, inevitably when there's a new mode of administration that patients aren't used to, they might say they're still unsure and prefer to hold off and see what else is out there.